Thanks for joining us on Not Boring CEs, where we don't think you should be bored to death while getting your continuing ed. Keep listening here, then hop over to notboringces.com to get all your online CE credits. All right, y'all, let's get to learning. Emily Foxen-Craft, PhD, is a pediatric pain psychologist with over 7 years of experience and the enthusiastic owner of Pediatric Pain and Behavioral Health. She provides treatment to children, teens, and young adults with chronic pain, chronic illness, and anxiety. Common concerns include headaches, digestive symptoms, sports injuries, and stress, but she always personalizes care to help the individual and family learn to manage their symptoms, improve functioning, and develop resilience for life. Dr. Foxen-Craft is a licensed psychologist in the state of Michigan, but is also authorized to provide interjurisdictional telehealth to 40 states through SIPACT. Prior to launching Pediatric Pain and Behavioral Health, she helped found the University of Michigan's Pediatric Chronic Pain Program as a postdoctoral fellow, and then as a faculty member in the departments of pediatrics and anesthesiology. She continues to conduct and publish research and to educate psychology trainees as well as pediatricians and pediatric pain management. Welcome, Emily. Welcome back to Not Boring CEs. I'm your host, Allison Pereira. I'm here with Emily Foxen-Craft, and we are going to be talking about pediatric pain psychology, which for me was an area I have a lot of experience in as a parent, but absolutely none as a clinician. And so I'm so excited about this conversation because I feel like it will help both those sides of my life. So thanks for being here.
Thanks for having me, and thanks for taking an interest in the subject.
Yeah, absolutely. So can we talk some about kids and pain? Because I think when we think of kids and pain, my first thought at least is usually acute pain, like broke their arm on the playground or has scabby knees or whatever. But that's not the majority of what we're going to be talking about today. We're going to be talking more about chronic pain, right?
Absolutely. So you hit on a number of great points that I would like to emphasize already. So first of all, you're right. Most people don't think about kids and pain in the same sentence, except for maybe the exceptions of, bumps and scrapes and injuries like that. So I just wanted to take a moment to say thank you to anybody who is clicking on this video to watch and for taking an interest in this subject, because it is more common than we appreciate and also more complex than I think a lot of people think at first face value. But anybody who's a clinician, who's maybe talked to somebody who's in pain, has realized that, wait, what in the world am I supposed to, how do I understand this? And how am I supposed to deal with this? So chronic pain and different kinds of pain conditions in pediatrics are actually quite common. And so, yes, we can kind of divide and classify pain in a number of ways, whether it's longevity of pain, acute to chronic, or the ICD, the International Classification of Disorders, Diagnoses, it has started in the newest iteration, has started to classify pain based on whether it's a primary condition or a secondary condition, meaning is pain itself the condition and the diagnosis, or is pain more a result or an effect of something else? And amongst those, we also understand a lot of different pain mechanisms. So across the board, pain is actually quite common in children. And so although we all are familiar with the acute or injury kind of often prone our kids in our lives, chronic pain or pain that's actually lasting a long time is also quite prevalent in kids, just a little bit more underappreciated. So depending how you capture it or how you measure it, how often how often in a week, for instance, you're assuming pain has to occur to be a diagnosis or a condition. Prevalence estimates vary and range from something like 10% to almost 40% of kids, which is a lot of kids.
Yeah, absolutely.
So you think about the kids who are maybe struggling with something like a stomach ache or a headache pretty significantly, maybe once a week, all the way up to kids who are maybe struggling with one or more locations of pain multiple days a week, or maybe even all of the time. And so whether the pain is coming from a bump or scrape, or whether it is longer lasting, there are a lot of great psychological tools and ideas that we can bring into our work with children. But as you mentioned, there's usually a caregiver or somebody else in the picture. And so thinking about the child and the whole family together, who are in distress and maybe in pain, and trying to think about the child in their lives and also in their context.
That's so interesting to think about, for potentially heritable conditions, right?
Mhm.
And how if there is a child struggling with some chronic pain due to a heritable condition, their parent might also have that, and the empathy or lack of empathy that may be coming
Mhm.
from the parent based on their own experience, um,
Exactly.
can really make a difference in how the child experiences pain.
Exactly. So whether they see a lot of disability or a lot of dismissal and invalidation, any extreme or anywhere in between, they're going to be observing and picking up on.
That's so interesting. I'm thinking too about like the prevalence being so much higher than I would have guessed. Like up to
Mhm.
40% is so much higher than my imaginings. Um, and it's something that we don't talk about as therapists, as people, as parents, as if it is that much of a problem. Um, and how that also communicates something to kids. There's
Exactly.
a lot of dismissal.
A lot of dismissal, a lot of assumptions of growing pains, or this is normal, or you're exaggerating. And so it's really complicated for both parents, caregivers, pediatricians, clinicians to really distinguish what's what in any given situation. On the one hand, we don't want to over medicalize or over pathologize things, but we also want to make sure that the kids who are in pain are feeling heard and getting into treatment, because that's the exciting thing about working with kids. Whether it's young kids or adolescents, is we have a lot of opportunity to intervene early before they kind of grow down the disability trajectory and into adulthood, where there are definitely long-term significant adverse consequences of having chronic pain.
Hmm. I'm thinking too about I've got a stomach ache as a like excuse, so to speak, of getting out of school. And
Mm-hmm.
how like I mean, parents talk about that all the time, like as kind of a trope, kind of.
Mm-hmm.
And how do we distinguish when that is a stomach ache, when that is a stomach ache caused by like medical condition versus anxiety versus it's something you can't really verify unless they're throwing up or having diarrhea or something. And so it could just be an excuse. Like how as a clinician do we help parents hear, listen, and ascertain which of those is going on?
That's a great question, and kind of my bread and butter and what I do day in and day out. So certainly I just want to remind everybody that luckily as therapists, we have sometimes the luxury of some time, although families are often in crisis and want a solution now, just thinking about taking things step by step, and that you may be able to figure out things in a moment, but also this could be more of a process where we're learning and refining our approach as we go.
Mhm.
So I think though, regardless, there are a couple of principles that you might want to keep in mind. I think going back to the dismissal and validation, I don't know how fruitful it always is to decide what is real pain and what's not. We really conceptualize pain, any experience of discomfort and pain, whether it's nausea or more of the classic kind of form of pain, really being the quintessential biopsychosocial phenomenon. It's going to involve brain, and it's going to involve parts of our body communicating with each other that are influenced by certain biological factors, that are influenced by mental and psychological factors, as well as the social context that we're in. So I don't know how fruitful it is to really say, oh, that's just anxiety, or
Mhm.
that's true pain. It really can be both. Of course, it is important to figure out if there is an infection or a fever or something like that going on. So that those might be some clues about the source of some stomach pain. But beyond that, first of all, just not trying to label it or dismiss it is a really good first step of just taking that pressure off of yourself as a parent
Mhm.
or a clinician. That being said, moving forward, if we've ruled out acute illness, And that's been ruled out either by, a parent's professional opinion or a provider. The idea is to move forward with a balance of empathy, of saying, I hear you, this is what you're going through, this is tough, but also a real focus on functioning. So even if a child is really struggling with chronic abdominal pain, the goal is to gradually help them overcome that and help them still figure out ways to maintain their functioning, like going to school, hanging out with friends, participating in sports, with their pain. Of course, we also want to include some strategies for helping manage the symptoms, prevent the symptoms, handle them in the moment, but also, regardless, the focus is on helping them get into school, get on with their lives, for a lot of reasons.
Yeah, it's interesting. This feels slightly related, but maybe not entirely, but because it's not pain, but having raised my kids who were really young during COVID, where if you have a sniffle, you don't go to school. Like you are meant to stay home. And now being in a place where you can have a full-on cold and go to school again, they don't have a sense of that. So they're like, well, I have a sniffle and a half, so I can't go to school. And us being like, no, you still have to function. Like you don't feel your best, but you're feeling great enough to play. And you're allowed to be at school now. So it's time to go. And it just being such an interesting schema shift for them of what you do when you don't feel good. Not just stay home and hang out anymore. That's the way it was a couple of years ago.
Yeah, that is a great parallel to think about that might be relatively universal right now. When you've been experiencing pain pretty recurrently or frequently, it does shift your mental set around what's typical, what's normal. Pain universally is a signal of our body being in distress. That's what it's meant to do. It's an adaptive response. So you can imagine the quintessential more acute pain, you bump your arm, you burn your finger. That signal is going to be really strong and really distracting and make you focus on it. It's going to be super unpleasant for the purpose of keeping your body safe so that you don't continue to do that and you don't do it in the future. So it's a learning experience as well. And so when we have chronic pain for whatever reason, that signal, we kind of have to uncouple it from that message that that's a danger and that's a threat. And that's something really hard to overcome and do because it's primed, it's natural within us to make those assumptions and those cognitive leaps when we're in pain. And so, and when you have the pain recurrently and chronically, it definitely shifts your mental set around your interoceptive signals.
How does it work for or like either anecdotally or what does the data say about parents who experience the same kind of pain as their children? Do they tend to be more empathetic or less?
I'll say clinically, I've definitely seen both. I think there is a large degree of concordance between parents' mental set and children's mental set around pain. So there is a construct called catastrophizing, which is an exaggerated mental set around pain. I hate the word exaggerated, but regardless, it's one that's commonly used. Or it could just be framed as a negative mental set around pain, which again, most of us don't have the most positive experience or thoughts around pain. But it's this, this response about pain and how negative or the degree to which the appraisal is occurring. And so there is a lot of interesting data out there about the concordance between parents and children, or sometimes the disconcordance, and what does that mean when they have different views on pain. What's interesting, though, is at least clinically, I think this is an area that is just emerging as an area of research in pediatric pain, is this concept of resilience. And I think it's particularly interesting in kids because there's so many factors about kids that are naturally resilient. They're, especially these days, are used to overcoming tremendous changes into their lives and disruptions. But regardless, kids are sometimes really motivated to although sometimes we're not so motivated to go to school, some very much are very motivated to live their normal lives and have fun with their friends and do their activities. And often clinically, I see kids who are much more accepting and open to trying different strategies and working through their pain. And sometimes it's more the parents who are the more distressed ones, or the ones who feel that things have to be fixed at all costs, which is a totally understandable perspective. We would do anything to protect and save our kids from any pain, but it is interesting sometimes to see that perspective.
Yeah, that's really interesting. Um, is there a correlation with the way parents model their own resilience for their kids? Like what do you think makes one kid or a group of kids more resilience focused and they still want to participate? Does it also have to do with the severity of their pain? Like if it's more severe pain and they know it's going to be forever, is it like they're more desperate for that connection and they're more willing to bear it? Like, explain the world to me.
Sure. That's what I love about pain. There's so many different offshoots that we can explore and think about. It is a relatively newer field, and especially in pediatrics, once we layer that concept of development onto everything, it is, the child pain research is definitely sometimes behind in some ways the adult research, because so much more is able to be done in adults due to numbers and due to funding. But there's some really innovative and thoughtful research being done in pediatrics. So I'm so excited to continue to keep up in the literature. Regardless, I think the question was about, behaviors and modeling, and what do we see, or what are some of the factors that help kids be resilient? And again, I think we can think a little bit about the Braun from Brenner model of kids being in their ecological context. So there's definitely internal factors that maybe predispose or help kids be more resilient. And there's definitely a lot in their social contexts and their development through time that affect how resilient they are. So there's lots of great internal psychological constructs that we see correlated with resilience, things like optimism and skills in self-care and certain mental sets and patterns and adaptive coping patterns. There's a lot about, internal locus of control and things like that. But there's definitely lots of psychosocial concepts that we see being related. So I'm sure a lot of you have heard of adverse childhood experiences, and that we've also, some research has started to explore positive childhood experiences. So it's not just the lack of ACEs, but the experience of these PCEs in children's lives that also seems to be related to better outcomes with pain, that may be indicators of resilience. So the things that some researchers have looked at with PCEs, although it's not as well defined sometimes universally as ACEs are things like having a resilient mindset in the family, but also living in a safe neighborhood, having other positive adult mentors in someone's life, giving back to the community and volunteering are amongst a set of different psychosocial factors that might help a child be more resilient in the face of pain. And then once we start looking at the characteristics of the pain itself, there's a number of different factors that we look at. So certainly the intensity, certainly also the duration. So you can imagine like an 18-year-old who's been really struggling with pain since maybe middle school may have a different experience than somebody who's starting to get weekly headaches and they're 10 years old. So that might affect things too. But also we look at things like the widespreadedness of pain is an interesting concept that I and some of my colleagues have looked at. So that's the concept of thinking about whether the pain is in one place, like your head, your stomach, your arm, or whether you have pain in multiple parts of your body or even all over your body. Can definitely that level, that distinction has been shown to be highly correlated with a lot of the outcomes that we're interested in, like how functional are these children, how much are they living their lives, their levels of anxiety and depression, sleep problems, fatigue. So a lot of those things as well.
Got it. Yeah. Oh, there's so many questions in my head all at
I
once.
know. That's why I love this.
Um, I think about children who are developmentally not in a place where they have a lot of language yet,
Hmm.
and how they communicate pain and what gets missed and caught later. Like, how does the communication of pain when you don't yet have those skills? How does that work for,
Great
yeah.
question. So you can think about age, you can think about different developmental trajectories and diagnoses impacting a person's ability to communicate about pain. So there's first the internal understanding about pain, and then there's the ability to express it as well. Um, so some of the most common measures of pain that you might see are definitely focused on the intensity of pain. How bad is it?
Mhm.
Um, and so you usually see that 1 to 10 scale or 0 to 10 scale. That might work for some children. Don't underestimate them. They've been asked that question before. If
Mhm.
you're the provider or the therapist seeing them, someone's asked them that before. On the flip side, it can be a very abstract concept for them. So first of all, if they are able to give you some response to the 1 to or 0 to 10 scale, I frame it to families like that's not an objective criteria. It does not mean that your 5 is better or worse than somebody else's 7 or 3.
Mhm.
But we can use that as a frame of reference for saying, are things getting better? Are things getting worse? So just kind of taking that pressure off, but really focusing on the person themselves, on kind of making a person-centered measurement system. And that's the creative approach I like to take with children or even young adults who may be struggling with communication, is really taking a personal approach, trying a few different things and seeing what clicks. So one great tool that works especially with younger children is bringing in familiar metaphors like a stoplight. So a lot of kids are familiar with the whole stoplight system, whether it's from learning about rules of the road, or sometimes there's some games that involve around that. And so I've helped kids kind of come up with a system of, red means it's really bad, green means I'm feeling good, and yellow is somewhere in between. And that seems to work well for some kids. You might even take out the yellow if that's too much to add. And the nice thing about that tool is that we can also layer onto it plan. So if I say I'm green, this is what my mom or dad are gonna do. If I say I'm red, this is what's going to happen. And so it creates that sense of predictability, and also some communication around that. So that's one kind of tool I like to use, because sometimes bringing in something that already has some meaning.
Mhm.
When we talk about pain location, rather than just relying on verbal, you can have them point to their body, point to a picture. That's one that's been studied and validated. There's a body map called the Super Kids Body Map, developed by a consensus group, I think related to the College of Rheumatologists, arthritis and rheumatologists. Sorry, bungled that one. But it is validated for kids as young as 8.
Mhm.
So use it with clinical judgment around younger kids. But that's one great tool that can be used as well. And certainly there's the FACES scales, and there's also observational tools that you can be trained in and learn more about. They're a little bit more intense, but they involve looking at facial reactions and different kind of utterances and body language as well.
Mhm. I'm wondering, is there a correlation between like age of onset
Mm.
and resilience?
Hmm. That's a great question. I'm not sure if I just haven't read it or if that has not yet been studied. The most kind of common age of onset for chronic pain, at least in kids, is more of the adolescent years or early adolescence, kind
Mhm.
of timed around puberty. So there is kind of a somewhat lack of research in even younger children because it's hard to get sample sizes at all in pediatric chronic pain. And
Mhm.
so much of the research is centered around those adolescent years when we can at least get some reasonable sample sizes into a research study. So I think that's one of the main reasons. I'm sure it's not the only reason, but it's one of the main reasons there is a little bit of when you look up pediatric chronic pain research, you'll often look at and realize those kids are teenagers, and there's not a lot being done on the pre-adolescent, school age, or even preschool years. So I think that would be an extremely interesting question to study. Mm-hmm.
Does most of the pain that kids feel, is it most of it have like a diagnosable etiology, or is it more non-specific etiology?
That's a great question. So a lot of kids come into clinics. Usually by the time they come into a pain clinic, they have collected a number of diagnoses because no one diagnosis is really capturing everything that they've been through. I think the field is continuing to revise diagnoses and clarify things. So the ICD-11, I think, like I mentioned earlier, came out with some new classifications around pain, which I think was really powerful because previously it had kind of been shuttled under other chronic pain. And so including it as a valid diagnosis, that primary pain can be a valid diagnosis, I think is really, really powerful first step. But some researchers have started to analyze the codes that are included in that and have realized that it may not entirely map onto the pediatric experience, but this is very new. So I think in the coming years, there'll be some research into understanding what maps onto pediatrics and maybe what are some gaps or maybe some additional diagnoses that they should create potentially for pediatric populations. But luckily, I think there are a few common ones that you might see in your clinic or that somebody might come in with. So there are certainly a number of migraine and headache diagnoses that somebody might have. There's kind of something called functional abdominal pain, which I'm not sure has a code, might be just other abdominal pain. But that's a common diagnosis that's given when the pain is kind of idiopathic or that there's no IBD going on. Similarly, there's some more musculoskeletal pain conditions that are pretty common in pediatrics. There's something called CRPS, complex regional pain syndrome, chronic regional pain syndrome. There's a couple types of that one. It used to be called RSD. So if you have any people coming in with that diagnosis, that maps on. And there's something called, there's some debate in the field about what it should be called. And that's called amplified musculoskeletal pain syndrome, or AMPS. I always tell that one to kids and because it's a mouthful. Other parallel diagnoses that you might see to that one are like juvenile fibromyalgia. So there's some debate about whether it's true fibromyalgia when it presents similarly in kids. So
got it.
Hence the need why somebody you could see might accumulate a lot of these different diagnoses depending on where their pain is presenting, which kind of specialist they've seen. So if you go to a GI, you're going to get a certain diagnosis versus if you see a headache specialist neurologist, you're gonna get a certain diagnosis. And some of these clinicians either aren't considering the person holistically or don't even ask, where else are you experiencing pain? They're focusing on their specialty. And so that's why we have the opportunity to think really broadly, think about a whole person and work with providers to help kids get the best diagnoses and the best understanding of their pain. And so sometimes, if they see a specialist, they get one diagnosis, but then you're talking to them and you're realizing they have pain in so many different parts of their body. Maybe there's something more holistic going on here, a whole central nervous system kind of condition rather than just having to do with this one body part.
Yeah. How much collaboration do you end up doing with physicians, like per client?
Sure, that's a great question. So up until recently, I had been having the luxury of working at a tertiary care medical center. So I was working directly in clinics with other providers. We were all on the same electronic system. So that was really fluid and really easy and a lot of collaboration. And since I've been in private practice, I've been making an effort to keep up a good degree of that collaboration. Although it's certainly harder because I have to get releases and it's not as easy just to catch people on the fly.
Right.
But I think it's really a great idea to continue collaboration because it is ultimately what's best for the patient or the family or client. As we kind of talked about at the beginning, there's so much dismissal and invalidation, cross messages, different messages, and it can be really overwhelming. for a family to try to navigate all the different messages, the ideas, and potentially even contrary recommendations. So I think it's really critical to be collaborating.
Mm-hmm. I'm thinking I kind of want to go back to the ACEs and the like PCEs.
Mhm.
When a child has pain and maybe a lot of ACEs as well, does increasing their PCEs help? Is that ever part of treatment?
That's a great question. I read some of that research and it was done in community samples. So it wasn't a treatment study per se or a clinical study. But it did seem like in the context of ACEs, having some PCEs mitigated or buffered some of those negative effects. So I certainly think that some of those things may not be in our control as therapists, where a patient lives or a family lives, may or may not have a good degree of flexibility. But I think there's a lot that is in our control, or it is in a family's control that we can empower them to work on. And I think it is a really empowering message because sometimes ACEs, I think it's so important for us to be so informed and so sensitive to those things. But it can sometimes feel a little defeating. Like I had this thing happen to me, and now my whole life, is going to revolve around that experience,
Mm-hmm.
and I can't change it because it happened.
Mm-hmm.
But thinking about, well, what can we add in to change long-term outcomes? And I still have a sense of empowerment about my life. I think is a hugely impactful message to share with children and families.
Mm-hmm. So just thinking about like treatment modalities and kids with chronic pain, what modalities do you see used with the most success? Are there any sort of alterations that need to be made for this population?
It's a great question. So the most commonly studied and described in the research form of treatment is called cognitive behavioral therapy, or CBT. And luckily, there have been books and manuals published on this subject. So there have been people who've studied how to adapt CBT for pain and specifically for children. Of course, when you're working with a specific child, you want to take still a personalized approach, and think about where their priorities might be or what's a good fit for them.
Mm-hmm.
But there's some really common core elements included in a pediatric pain CBT approach that can be useful, I think, for most children, regardless of their diagnosis or particular etiology of pain or duration of pain. So that's the most commonly described one. For children and like really young children, there may be adaptation of more behavioral principles, focusing on parent management and then teaching some more behavioral coping. As children develop, start really thinking about 7, 8 years old, we might, again, on average,
Mm-hmm.
we may be able to incorporate some more of those cognitive strategies. And as children even develop further into adolescence, I think it's really exciting to be able to bring some ACT principles into there, because there's a lot that we can do with cognitive diffusion and acceptance and values-based living, that I think is very applicable
Mm-hmm.
for a lot of children. So I think there's a lot of great move to incorporate some of these different techniques. And there is some emerging literature around more positive psychology around this resilience building. So not just fixing a problem, but
Mm-hmm.
developing positive resilience and growth are some of the exciting things that I've seen. There's some new stuff about pain reprocessing, which I think is just an application of CBT principles that we've seen pop out. And then those are the ones that I think, are more directly related to most children with chronic pain. But I think it's important to take a lens on what is going on with a child's life. So are they coming in with a history of trauma? Are they also very depressed or very anxious and have developed some GAD? Maybe part of it's related to their pain, part of it's not. And so thinking broadly about the treatment and what components of treatment are relevant for a particular individual, you may be thinking just because they have pain, you may still need to be thinking a little bit more broadly.
Mm-hmm. Got it. I'm thinking about like therapists who are already working with kids for like other presenting concerns and then
Mhm.
find out um, this child has some chronic pain that's been going on that either has or hasn't been disclosed to parents.
Mhm.
What would you tell this therapist who isn't as well researched as you, doesn't have the clinical experience with pain? Like, is this a child that should be referred to a specialist? Is this a child that can be handled by this clinician with some consultation or some extra learning? What would you recommend?
Sure. So I think all of the above options are on the table. And so maybe here are just some things to think about, and some options to, consider, or a way of, or a framework of thinking about this. So first of all, validate the fact that they're bringing it to your attention and say, hey, this sounds like it's really important. Assess a little bit more what's going on. If it hasn't been shared with anybody else, why is that the case? Is it just new? What's the reason going on there? And also really try to assess the impact on functioning. So is this maybe one of the reasons that we're not going to school, or that we're nervous about going out in public, or things like that? So kind of getting a sense of how, if you think about a person as a whole, to what extent is the pain part of their experience and part of what's affecting their lives? And that might guide you a little bit in your treatment. So if this is a portion of what they're dealing with, but it seems very related to the work that you're already doing with them, I think there's so much that therapists don't realize that they can do to help with pain that is in your toolkit that you can use to help. If for whatever reason, either it feels completely out of left field, if it feels like you're already trying to tackle so much and pain just doesn't feel like something that can fit in with your treatment plan, or maybe if it's impacting functioning more and you've tried a few things and it's just not clicking or going anywhere, you and the family feel a little bit out of your depth, that's a great time to reach out for either consultation and some guidance, or maybe to refer, and it could be a collaborative treatment approach. So I think all of the options are on the table. So there's a lot of things that therapists, like I said, can do that are probably already in your toolkit that you can use to help. So if we think about CBT, for instance, if that's an approach that you're comfortable and familiar with, just taking a moment, reading through a treatment manual or reading some articles online. I think I've linked we might be linking a few resources to this session today that may be able to guide you into saying, oh, I didn't realize that's how I could just tweak that one or apply that one skill. So some common things are working on behavior change. That's a thing a lot of us do. And so sometimes there's things like sleep management, activity pacing, thinking about someone's time management and schedules, that might really play a role. Goal setting, solving problems. Those are skills that a lot of us help clients with all the time. And then changing our thoughts and changing our reactions to uncontrollable circumstances is definitely something many of us do. And so if you're comfortable working with children, there's probably a lot that you're comfortable with doing when it comes to pain.
Okay, that's good to know. I'm wondering about unsupportive parents and how clinically you manage that.
Yeah, that's a toughie for any challenge that any of us are facing. But I was wondering if you could tell me a little bit more about what you're envisioning, or maybe a hypothetical.
Yeah, so maybe I'm imagining parents who are like, oh, it's just anxiety. Like if you stop focusing so much on the pain, they'll stop acting like they're in pain all the time. Like that kind of idea. I'm thinking about a family that I've known, of just don't pay any attention to it and it'll go away. That kind of a mindset.
Yeah. So one modality of treatment that I have not really brought up so much yet is motivational interviewing, and that might play a role in something like this in combination with some education. So first of all, there may be kernels of what somebody's saying that are true, right? So maybe there's a kernel of what this parent is saying that, hey, the attention that we pay to pain does factor in, right? And then the more we do avoid doing things, the bigger they seem. That's all true for sure. And I'm so glad that you recognize that the mind and brain play a role in our perception of pain. So many parents don't realize that. But I also want to think about the biopsychosocial phenomena and recognizing that this is a two-way communication between the brain and body. And there's something off here that it keeps perpetuating. So why don't we work together to help get your child to your goals of getting to school and not avoiding things, but take things step by step in a way that helps them get there, because what we've been doing so far hasn't.
Mm-hmm. Yeah. I love how like empowering you are to the parent in that conversation. Because I'm sure like internally I would be feeling some frustration as the clinician of like, trust your kid, believe your kid, you know. Yeah, I'm thinking about how you were talking about the onset is often around puberty, basically, when so many other changes are going on, emotionally, physically, all of it. Hormones are wild. Um, are parents sometimes late to the game in realizing something needs to be addressed because it's like chaos already? And they were waiting for it to settle down, or it was just a growth spurt or whatever. Is there sometimes some delay that happens?
Yeah, there's definitely delays to treatment or delays to diagnosis that we see in the literature and I see clinically. And I think some factors are right related to, if it doesn't seem super intense, super urgent, we kind of wait and see, which is not
Hmm.
a bad approach for a lot of things.
Hmm.
So there's that component. And then there's the component of working your way through a medical system that just takes, unfortunately, so much time. So you get in to see your pediatrician. The pediatrician says, okay, let's wait a few weeks and come back and see what happens. And then
Hmm.
they see that it's not going away. And so then maybe you refer to a specialist and that takes forever. And then they say, oh, maybe now you need to go to a pain clinic. Because to get some rehabilitation or some education around it. And in that interval, it could be years,
Hmm.
and the pain could have gotten worse. So I think there's so much that we can do if we're on the front lines of working directly with families, and partnering and serving as educators as well to our colleagues in different disciplines.
Absolutely. And I think like about pain meds and kids and adolescents.
Mm-hmm.
Talk to me about that.
Yeah.
Yeah.
So I'm not a prescriber.
Mhm.
So certainly, listen to people who know a lot more than me on the subject, but I'll touch on it just for a moment. Luckily, I think for the most part, the education has gotten out there and most prescribers are wary of providing narcotics to children.
Mhm.
There's a lot of regulation even around things like post-surgical uh, prescriptions.
Mhm.
So I think parents, providers are certainly wary, but at the same time, a parent will do anything at all costs to help their child.
Mhm.
And sometimes there is some very understandable medication seeking, and certainly a provider too, who either is not as educated or is desperate to try to find something that helps. Will try different things, maybe thinking at first it's going to be a short-term thing.
Mhm.
However, the consequences of opioid type medications for children are pretty extreme. And especially with the kind of pain that we've been focusing on so far today, which is chronic pain, opioid medications have been typically shown to be actually more aversive, have more adverse consequences than benefits. And in fact, I think this is the one thing that's surprising to some people. It can actually cause hyperallodynia, which is more pain.
Mm.
Body kind of, I think, becomes a little tolerant of it and the signals just become amplified. So it can actually have much more unintended consequences, and even make things worse than they were before. So I think that in terms of what we commonly think of as pain medications, opioid medications, there's a huge move to move away from that for most children in most circumstances. And if you have questions about that, these are great times to be teaming up with a prescriber to ask these questions, learn more, and work together for the well-being. That being said, there are some new non-opioid medications to help with different pain complaints. I hate that word, complaints. Um, but regardless, some of them may be focused on the global body pains, focusing on the central nervous system. Some may be focused or prescribed more specifically for different kinds of presentations of pain. So there's some migraine and headache focused medications, and there's some GABAergic related medications, and sometimes SSRIs are used as well. And so there's no one chronic pain medication, but several have been used in pediatrics. But also sometimes there's some really great data that show that the combined power of psychology and medications can sometimes be greater than the individual components. So I think there's some work that's been done in headaches, and some works that's been done in headaches that show that none of the commonly prescribed medications were better than placebo. So I think there's a lot psychology offers in combination with the medical approach that could be helpful for children. And there's been a lot of calls to have CBT, to have psychology therapy be a frontline treatment, as opposed to let's try medications, and if that doesn't work, then let's go to therapy, and it's kind of our last resort. So I think I appreciate when people are able to push that out, that this is not stigmatized. We're not saying it's all in your head, although if it's headache, it probably is. Um, but yeah, I think they're, educating yourself. If somebody comes in and they're on a prescription, learning about it, talking with the provider, doing some research, understanding how it affects a particular individual. Are there positive effects? Are there negative side effects that they're dealing with too? And learning about those to help the individual in front of you.
Yeah. I think too about the difficulty with kids communicating and referred pain, and how that can sometimes be like where the pain shows up may be a bit of a red herring for the family. Like I'll share, I shared this with you when we first spoke, but my youngest daughter, or my oldest daughter, when she was 5 or 6, she was 6 and she was throwing up all the time. And we went to her neurologist and we were like, is it her seizure medication? And he's like, she's throwing up like 8 hours after she takes it. I don't think it's her seizure medication. I think she has migraines. But it never occurred to me that a child that young could have migraines. Like, it just wasn't on my radar. I thought maybe around puberty. And because she was never complaining of a headache, like not once. She just had like gastric migraines. And so we kept thinking it was some sort of gastrointestinal issue until we had that conversation with him. And then just got on some, like he'd suggested some supplements, just some vitamins really, that have helped keep them at bay, which was wonderful. But how those of us who don't know or understand the body or what can happen, or make assumptions like I did, that developmentally she wasn't there yet for a migraine, like we can miss big important things just because we don't have the experience or the information. Yeah.
Yeah, that's complicated. That's why this field is so complicated. On the one hand, there are so many avenues to try to come in and help on all these different angles. On the other hand, it could still continue to present mysteries to us. And so I think the biggest thing, I think, as a therapist is really being a partner and an advocate for the child and family that you're working with. Make sure they're getting connected with people and helping coach them. Okay, if I go to an appointment, these are the questions I should be asking. And this is how I can monitor my symptoms to track progress, to be able to tell a physician or somebody like that, and working on the background on the back end to talk with them and share with them what you're learning. And working together to try to help understand things. So you were not wrong in that situation. Like we said, most chronic pain starts to occur around puberty. And people don't often think migraine in younger children. I've seen, photos and ways of diagnosing children, even in infancy and preschool. So
Wow.
it's rarer. It certainly comes on, and then this, either cyclical vomiting syndrome or abdominal migraines as a whole. It's a whole thing too. But yeah, you're right, and where the person's having pain may not be the complete story, at least. And so just asking a lot of questions, working together to try to understand somebody's entire presentation. I think often we have the luxury of talking with children and families with a little bit less time pressure and more frequently than pediatricians and physician partners. And so we can really help even if we're not the ones that are ultimately responsible for making an accurate medical diagnosis, we can be helpful in gathering information, distilling it, presenting it back to a family or back to a physician or partner, to help work together as a team.
Mm-hmm. Yeah. And I think like it really speaks to that holistic piece, because we had gone to the pediatrician with stomach pains, and talked about diet and talked about, is it reflux? Is it this? Is it that? And it was just not on anybody's radar.
Mhm. Yeah.
Yeah, which can happen so easily, even with really great providers.
Mhm.
And what's the role? Like, let's say we had come to you and mentioned that as a therapist, is it like within your scope to be able to say, like, I think this may be potentially a migraine. You should talk to your doctor about that possibility. Like, what's within scope there?
Great question. I think it is a delicate balance. So, as a pain psychologist and having had the experience of working in the clinics and in a specialty pain clinic, and embedded in different specialty services, I do feel like I have the language and the radar, and know a lot of the questions that would be asked. But I really try to gauge it on a family by family basis. Do I feel like if I share a question about a diagnosis or a name of one, how's that going to affect this family? Are
Mhm.
they going to latch onto it and be like, she diagnosed us with this? Wait a minute.
Right.
Or do I feel like they would understand that this is is a way of asking a question, and either way of conceptualizing, even if it's not a firm diagnosis, or it's a way of taking that information and asking a medical provider who is qualified to make a diagnosis. So I think I would kind of read the room
Uh-huh.
essentially.
Got it.
um, there are, yeah, I think it's important to be a good partner to a family, help them connect the dots, but also leave the right work to the right person.
Mhm. Got it. Um, are there ways in which you see therapists sometimes overstep when it comes to pain, like something that we can all be really conscious of going forward so that we don't do that?
Yeah, I think balance is a key word. So if you are starting to notice we're leaning into one extreme, right? We're leaning into pushing them to do everything and completely ignore their pain, and it feels really extreme and kind of boot campy.
Hmm.
Alternatively, if we're leaning too far into, oh, just rest, it's your body, it's, completely don't do anything, stay at home, don't go to school, kind of completely withdrawing from life, those might be indicators that we're missing something in our conceptualization, missing something in our treatment approach. And so those would be kind of common errors I see, or not errors, but common tendencies I see that are have good intentions, but
Hmm.
sometimes end up backfiring a little bit.
Got it. Yeah. I think about how we are a culture of dichotomies in the United States. And it's very much like go hard and hustle, or it's self-care and slow down. And I just want a slow life. I feel like there's very little talk about the in-between and that balance that you just referred to. Um, and I'm guessing that, and I'm curious if my guess is accurate, like the parents' bent is what they then pass on to the kid. Um, and how maybe the therapist's bent might also be something to be aware of. Is that accurate, or do you see it sometimes going the opposite?
Yeah, I think sometimes we try to do the opposite of what we've been told or what we brought up with, but we more often than not end up living it out ourselves. And so that's a good opportunity for, any therapist to ask yourself what your own pain experience is like. What are your own beliefs and experiences and thoughts that you have about pain, whether it's from a personal experience or somebody in your own life. Maybe use this opportunity to educate yourself a little further on what's known, what's still unknown, out in the world about this field, and try to bring in the strengths of your experience into your therapy session as appropriate, but keep an open mind that everybody's experiences are going to be a little bit different, and trying to keep the what's best for your client or the child in front of you in mind. I like to always start by asking, families, what's your goals? What are your values? And starting there.
Mm-hmm. Yeah. And I think about, as a parent, like my knee-jerk reaction to that is like to make the pain stop forever, And so like clinically, how do you work when families have unrealistic goals, or how do you break it to them that like this is an ongoing thing that will be ongoing potentially forever?
That's a really hard thing to hear. And it's hard because we don't have great data on like exactly what's going to happen to your child, or these are the exact rates of outcomes, because with pain we have so many different possible outcomes that we could look at that might matter. It's hard to narrow down certain percentages of like this many children get better, because what is getting better? Right. And so I try to help families put that out there. Hey, we'd love for this to all go away. But then I kind of take it in two different directions. I say, first of all, well, if you got better, what would be better about your life? Right? If your pain went away, kind of that, magic question kind of thing. If the pain went away, what would be better? Oh, well, we'd be going to school and we'd have fun on family activities and we'd live so carefree. And I say, okay, these are the things that actually really matter, right? We need to be going to school. We need to be having more family time and family activities, and we need to feel confident and prepared. And while to a degree, maybe these don't exactly occur on the exact timeline that we want, or maybe we get part of the way, but those are the things those are also the targets that we should really be keeping in mind. Another way of asking that is, how can we look at either proximal goals? So, okay, let's say the pain isn't gone by tomorrow or next week. What would be at least a step in the right direction, right? But also kind of keep in mind, well, what are the more ways we can measure success, I think the better we can be. So I always try to do some exercises around some flexible thinking around that, and include the child in that. They probably have things that they care about too, and trying to at least start with the common ground between those lists. Sometimes there's some differences. But the more we can include some functional goals in there, often the better we can be.
What if there's some sort of associated disability or something like that, where like you're not going to be able to play baseball while you're in your wheelchair, that kind of a thing? How do you manage that as a clinician while having that conversation about what do you want for your life?
Yeah, that's a hard one, is being attached to certain timelines. So I'll often be faced with somebody being like, well, tryouts are in 2 weeks. Kind of having a timeline around that. So we always try, because I think the goal is to attach the goal to something meaningful and important to somebody, but also being realistic. And so maybe saying, okay, well, is there a way to also do baseball for the joy of fun, for the joy of baseball? What are some things that we can do in between now and then? Can we, play a little catch even in the wheelchair? What are the stepping stones to getting up and moving? In the clinic I used to work in, I had the luxury of working with some amazing physical therapists. So I think those are also people that we haven't talked about so far in this talk, that are really underrated and can be incredible partners at helping with rehabilitation. And there's so much that goes on with the physical rehabilitation that goes on with the mental rehabilitation in parallel. And so those are some of the most exciting partnerships I've ever had, and I continue to nurture.
Yeah, I love that. And I think about OTs also as being part of that team, and being able to just,
there's
really
so much
surround the family.
Unappreciated and sensory things that start to happen, sensory sensitivities that begin to happen with chronic pain. And so, partnering with as many people as you can get on board. There's a lot of CAM, complementary and alternative medicine people that can be incredible. A little less research on some of those areas. So I always tell families when they ask me about that unfortunately there's not a lot of literature, not a ton, especially in pediatrics, that I can go to make a strong recommendation. But if you have people that you like, that you think are sensitive to families, won't do harm, then those might be great people to have as part of your network to help refer, cross-refer, and build a little team.
Yeah, I love it. I'm thinking too, just like recognizing your passion in working with pediatric pain and it being a less researched field. Like, does that get frustrating sometimes? Is it more exciting? Like, what's the emotional experience for you as a therapist in this kind of up and coming with knowledge field?
All of
Uh-huh.
it. But yes, I wish we all knew more, but it's an exciting field to be in because there are so many great questions that you can
Mhm.
ask, and that have yet to be asked. So luckily, I think there's enough out there that we feel like we can start, right? There's enough out there, and there's so much great, amazing work that's been done by some really incredible, dedicated researchers and clinicians that we can draw upon in our clinical practice. But I think, we should all always be paying it forward and doing what we can to help good questions get answered, and push the field forward so that we can understand more things um, and help children more and more grow and thrive. So whether that means, I continue to keep up some of my partnerships in research and write papers, whether it's bringing up-to-date research back to children and families and the public, whether it means, engaging in advocacy and research in some different avenues, even in community health or private practice. I think there's a lot we can do.
Amazing. Or doing CEs like this to help educate other therapists.
Exactly,
Yay.
exactly. No, I think there's so much that you already know that you can draw upon and help serve as community leaders.
hmm Is there anything else you really want therapists to start to understand about pediatric pain that we haven't talked about yet?
I think we've thrown around the word biopsychosocial a few times, and I just really want to emphasize that I don't take that word lightly, and I mean every single component of it, plus probably more cultural, developmental factors. There's so much that goes into the experience of pain, and so truly is not a dichotomy. There's not body pain and emotional pain. It's all intertwined. We know that on a neuroscience level, we know that on an experience level. So I think just really moving away from that dichotomy or trying to label a pain and really understanding it deeply for yourself and being able to communicate that with confidence, to people that you may come across, that pain is a connection. Pain is a communication between the brain and the body. You can't have one without the other, to experience this phenomenon. It's a phenomenon, a sensory phenomenon. So it all goes into it. Maybe some experiences have more of one than the other, but we all have a role to play with helping children with any form or mechanism of chronic pain. But there's a lot of resources out there. A few of them are being shared today. And you can always reach out to somebody. So a lot of children's hospitals may have experts, or just Googling, and me would be happy to always help.
Amazing. Thank you so much for talking with us, Emily. For those of you watching or listening who are interested in pain, Emily has some others that she is doing with us. So make sure you tune into those as well. And yeah, I will see you soon. I hope that broadened your clinical horizons. Head over to notboringces.com to get your CE credit. Want to have a not boring conversation with me about your clinical area of expertise? You can apply there too. If you like this conversation, leave us a 5-star review, tell a friend, and be sure to subscribe for future conversations.